Good afternoon, everyone. Welcome. Thank you for tuning in today for this very important discussion. We are here today to talk about mental health. This is our forum for February 2023. Today is the last day of Black History Month, and I hope you've all had an opportunity to enjoy and reflect on the meaning of that month. Today's topic will be mental versus behavioral health. What is the difference? The terms behavioral health and mental health are often interchangeable, but they don't always mean the same thing. What is the actual difference? Why are they important? How can we improve both? These are important questions we will seek to answer today. We have assembled an amazing panel of experts to have this conversation. For the first time in a while, all of our panelists are from our own CDU. Each has their own perspective to contribute to this discussion. Dr. David Martins is a graduate of the University College of Hospital in Ibadan, Nigeria. He completed his residency training in internal medicine right here at CDU and holds a Master of Science degree in clinical research from UCLA. He's currently Associate Professor of Medicine at CDU and is a noted expert on hypertension. We are also joined by Dr. Denese Shervington. Welcome, Dr. Shervington, Chair of Psychiatry and Professor here at CDU. Dr. Shervington has testified before the United States Congress about childhood trauma and has authored several published papers addressing health disparities, the social determinants of health, and resilience in underserved communities. Rounding our panel is our usual leader, Dr. David Martins. He is President and CEO of CDU. Dr. Carlisle is a board-certified internal medicine specialist and served as Director of the Office of Statewide Health Planning and Development in California for 11 years, not under one governor, but under 3 different governors. So we're going to start out today. Just a second to get my paper straight. All right. The first question for all of you, though I invite Dr. Shervington to start with her answer, is the obvious question for this discussion. How do you define mental health and behavioral health? What is the difference, Dr. Shervington?
Let me unmute myself and just express my honor of being with such an esteemed group. And so I'll share the little I know about mental health and behavioral health. But I want to back up a little bit and give the definition from the World Health Organization on mental health. And they define mental health as a state of well-being in which an individual can realize their own ability, they can cope with the normal stresses of life, they can work productively and fruitfully, and then they can make a contribution to their community. And so now, since the pandemic, everybody's talking about mental health. Mm-hmm. And I kind of want to step back a little bit and say, what are we talking about when we say mental health? What is the mind? And so I want to remind us that the mind is really the expression of brain activity, and the essential function of the brain is to help us to get our biologic needs met in the world. It is how we will survive and continue. And what the mind does is subjectively interpret how the brain is responding to our internal needs to have our body survive and the environment in which we live to get our needs met. And so how we traditionally think about the mind is we have our feelings, and everybody now is talking about getting in their feelings. We have our thoughts that go along with our feelings, which express how we are perceiving our environment around us, and our behaviors. And behaviors are really the outputs of our mind. So the term behavioral health was used to more focus on how one's habits and one's behaviors are impacting our physical and mental health. And usually when we say behavioral health, it encompasses not just the usual way we think about mental health, but certain behaviors, in particular addiction, that can impact our health. But there's not that much. Some folks say mental health, some say behavioral health, some people say emotional health. It's all about our mind. And the one thing I want to end with is that our mind is the only organ except our skin in the body that we know. We have a sense of what our mind is doing, and it is an organ of the body. So thanks for this opportunity.
Thank you. Dr. Martins, do you want to respond to that? What is the difference between mental health and behavioral health in your view? Unmute. You have to unmute yourself.
Unmute.
Sorry. I think Dr. Shervington actually did find justice to that question in the response she gave, because one thing that it's obvious to every human being is the connection between the mind and the body, right?
Mm-hmm.
Even without that definition, we all know that when people fall sick, they feel sad. You know, that is one way the body affects the mind. And in hypertension, I've come to realize that hypertension, blood pressure, is actually one of the ways the body responds to your state of mind. For instance, we don't diagnose people hypertensive on one single blood pressure measurement, because we realize that in a new environment, they might be a little bit anxious and their blood pressure might indeed be elevated, right? So there is a important connection between the mind and the body. And generally speaking, being calm in your mind will promote health. And when you're chaotic and anxious, depressed in your mind, you will experience bodily sensations that will reflect that tension. And to be frank and honest with you, it doesn't just happen while you're awake. Some people take these worries into their sleep and they have nightmares. I mean, there are remarkable ways in which the body affects the mind and the mind affects the body. When your blood sugar drops in your sleep, you get a nightmare. You will see somebody chasing you, trying to kill you in your sleep, and you wake up. And nightmares among diabetics is an important sign of low blood sugar while you're sleeping. So we have remarkable examples, both clinical and non-clinical, of the relationships between the body and the mind. And we're still evolving in these areas because it is always mind over body at all times. You will be healthier, you will live longer if you have better control of your mind, because ultimately then you have better control of your behavior. You can choose your response. You know, that really is what I have to add to the intelligent answer Dr. Shervington gave already.
Thank you. Thank you. Dr. Carlisle, behavioral health and mental health are often lumped together. What's the risk if the public, as well as the medical community, do not differentiate between them? Dr. Martins has just said they're connected, but now I'm asking you to say how the public should distinguish the two.
Well, I would say it's kind of like a Venn diagram with two overlapping circles, and those circles overlap almost completely. And the reason they overlap almost completely is that there's really just a continuum, as the other panelists have talked about, from behavioral health issues into what we might call mental health issues. But in my mind, they're really the same, because the things that we used to call mental health issues really manifest themselves in behaviors or thoughts or dreams. But it's kind of how you are perceived by the outside world or how you perceive yourself to be. And that's really behavioral. You can have no mental health issue and have aberrant behavior, or you can have a mental health issue and nobody would ever know about it. There's a continuum of situations that that range from having no outward appearance of any challenge to being very severely impaired. I know one of the things that I'm concerned about, and the reason I and many other people have stopped using the term mental health as much, is there's kind of a stigma associated with it. And there's even a slur that people use. Oh, you're mental. That person's mental. That person's crazy. I mean, those are terms that people throw about, but they're stigmatizing. And they really don't capture the humanity of people with behavioral health issues. And the real point is somebody with a behavioral health issue that is severe, I'd include things like schizophrenia in that category, is somebody who can lead a virtually normal life under the right circumstances. So we need to remove the stigmatization from these conditions and basically say it's not exceptional necessarily to have a mental health problem. Most people at some point in their lives have had a brush with a diagnosis in this area. Let's kind of normalize this a little bit more. Let's remove the stigma and just call it, think about it in terms of behaviors, basically. And when you think about it in terms of behaviors, yes, there's a continuum from, somebody who seems very, very lucid, connected, to somebody who is incapacitated. And everyone has these issues. And the good news is that these issues can not only be treated, but can be improved, even with self-help steps. So I'm especially concerned about the stigma associated with the term mental health and those terms that I mentioned. Oh, you're crazy. Oh, you're mental. That really doesn't do anybody any good when we think about things in those terms.
Well, that's very helpful, especially if you're in a community of, let's say, professionals like CDU. But Dr. Shervington, what impact can living in an under-resourced community like South LA have on mental health and ultimately on behavioral health?
And I guess for me to drive it home is the mind is an organ in the body that reflects brain activity. And we have our emotions, we have our cognitions, and as both Doctors Martins and Carlisle have mentioned, the behaviors. And behaviors, which are these, how we observe the outputs of how we are reacting in the world. So I try to say to folks, it is an organ. Your mind is a part of your body. There's no mind and body, it's mind in body. And so, but to get to the more specific question about living in areas that are challenged, I oftentimes say poverty creates mental health. It's very harsh. It creates a grind. We living in areas where there is not access to basic survival needs. The body is the brain, that's the function of the brain, to help you figure out how to get your needs met in an environment that doesn't necessarily care about who you are. You're just an object in the environment. So when there is deprivation, it's going to impact our minds. And we have seen in certain measures that living in areas where you can't access those basic needs, where you're bumping up against racism and discrimination and there's violence, we now know that it impacts the brain. It impacts the hypothalamic pituitary axis. There's toxic releases of cortisol. Usually cortisol is there to tell us, you have a challenge, we were going to get your body revved up to meet it. There's something somewhat slightly or largely threatening your survival. But if you're constantly living in an environment where there are all these negative inputs, your brain begins to over-secrete cortisol. It can impact your functioning. It can make you, certain areas in your brain more hyperactive than they need to be. And so other than how we are resilient and resist these forces, environmental forces working against us, it is very hard to maintain a stable mental health when there's so many external challenges to one's survival.
That's probably true for all communities, but you're saying it's harder if the economic situation is. Dr. Carlisle, what role can government and policy play in improving mental and behavioral health? What has been successful so far?
Well, this is not my clinical specialty realm, and I certainly defer to our campus expert here, Dr. Shervington, on this topic. But government recently, both at the state and federal level, has been very active in the behavioral health realm, recognizing, especially because of the psychotrauma of the COVID-19 pandemic, but certainly before that as well, the issues of lack of adequacy and lack of adequate access to behavioral health treatments. We know about community trauma. We know about community psychology. We have a community psychology program here at CDU now. These are terms that we probably didn't think about or didn't really even exist some years ago. Now government has embraced these terms, and now government is recognizing the significant toll that behavioral health issues, stress, depression, et cetera, going on to the full spectrum is taking on our society and communities in our society. And government is starting to provide resources. If you, I think, asked most people from the state of California, maybe what is the most active health policy issue today facing the state of California? That answer a year or so ago would have been COVID-19, of course. But but today it might be, especially with the end of the pandemic emergency today, it might be behavioral health issues. And certainly the issue of behavioral health, the challenges there have existed for years. So when you think about a sustaining challenge facing government, it's behavioral health. The state of California is funding training programs. The state of California is trying to put other resources into communities that have poor behavioral health resources. The federal government is doing the same thing. So I think government, because of champions like many people, has identified behavioral health as a major policy area of focus, and I'm very appreciative of that.
Thank you. Dr. Martins, your master's degree from UCLA came from the Department of Biomathematics. Tell us what biomathematics is and what role can it play in addressing mental and behavioral health in communities. Dr. Carlisle is describing the situation and our consciousness of it, which has gone so up so far. Are we measuring whether we're being successful? Is the work that you've done helpful in that regard? What is that work?
Well, I went to the Department of Biomathematics to get trained in clinical research, but biomathematics is basically the mathematics of biological variables. And basically what we just do is we gather data, analyze them, and summarize them and see what they tell us. But in terms of how research of biomathematics can influence our knowledge and education on behavioral health, I would just like to use the example of compassion. Compassion was a concept that we talked about for so many years, but depending on who you're talking to, compassion meant different things to different people, and it was mostly restricted to religious circles. And now we have brought it up to the forefront. And actually, the community faculty members of Charles Drew University were very front and center in describing the early concepts of compassion, which have a lot of influence on how do we begin to set standards for ourselves in the community on what is acceptable and not acceptable behaviors, and how do we begin to understand why some people behave the way they behave. Because you see, like Dr. Carlisle said, the behavior is perceptible, but the mental processes behind it are not often perceptible. It is quite possible for somebody to be severely depressed and to behave normal, right? And you will not know that they need help. And it is also possible for somebody to be mildly perturbed and they will act out in ways that you will not believe. So sometimes we are not often in sync with ourselves, and our expectations from the community is also somewhat challenging, especially in under-resourced communities, right? You see, in under-resourced communities, we have scarcity of resources, both human, material, and everything. But if we can just work a little bit closer together, if we can just care a little bit more about one another, if we can be a little bit more compassionate towards one another, we can actually make do reasonably well with the little resource that we have. Because my understanding and I appreciate this more in the clinic setting, right? When you see people suffering, not because they don't have enough, but they're not making good decisions on how to use the little they might have. I'll give you a very good example. I saw a patient a few years ago. She's been healthy and fine all her life until her husband died. And then when her husband died, her sons decided that they were going to sell the house. And they did not make adequate provisions for her, or the provisions they made for her was not acceptable to her. That caused us so much stress that our blood pressure spun out of control, and I was forced to call a meeting of her and her sons and let them understand how the decisions they're making, however casual it may seem, is dramatically affecting their mother's health. It is interesting that they went back to the drawing board and decided to leave the mother alone in the house because they realized how much impact it was having on our health. So these are the sort of things that we deal with in our society and in our community in terms of behavior. But until we can begin to measure some of these things and actually compare them across communities and see what makes some people react like this to this same set of circumstances different from these other people. What do these other group have that these don't have that determines their behavioral responses to different mental health challenges and states? And now all of the answers reside in research, which we learn in the Department of Biomathematics at UCLA. Of course, biomathematics is way broader than that, including things like evolutionary biology and computational biology and all those things. But all of it.
But does it include mental health? What can you measure? You can measure how your diabetic patient is doing. You can measure how your heart patient is doing. How can you measure and quantify how your mental health patient is doing?
We have the scale for depression, right? We have a scale for anxiety, and now we have a scale, one of which we developed for compassion. There are scales. The challenge we have in research when you begin to measure behavior is you want to be able to relate that behavior to some biology variable in the person, right? So for instance, people that are more compassionate how does that reflect in their biology,
Mhm.
right? It was one of the reasons that in our ghost model of compassion that we developed at Drew, we identified some key components of compassion that have been shown to have biological benefits, things like generosity, sharing time and resources with ourselves. Not only does it make what we have appear a little bit more, it also promotes comforts with one another in the community. Hospitality, right? When you feel like you are received, you are accepted, again, it affects your perception and your mental state. Objectivity, when you walk into a place and you're sure that people are going to judge you objectively, not because of some prejudice or some bias, right? It enhances how comfortable and well you will feel in that environment, and ultimately tempers your behavior in that environment. Sensitivity is another component we did talk about in the model, right? We talked about, preempting and reacting preemptively to people's vulnerabilities. And then we talked about tolerance, right? Tolerance to all of our shortcomings. All of these things are behaviors that we want to standardize, we want to characterize, we want to promote, but the community needs to know exactly what it means. How should I respond to somebody that is sad around me because they just lost a son? How do I respond to a blind man walking towards a manhole? Do I wait for him to fall in the hole and call 911? Or do I raise my voice and run up to him and tell him, wait, there is a manhole in front of you? You see, what we really need to begin to talk about as a community is to begin to develop behavioral standards for our community. What do we want? What does it mean to be a human being living in this place? What are the expectations? What can I expect from you as a neighbor? What can you expect from me as a neighbor? All these things will work together to really ensure that we live healthy and happy people if we can come up with that. And we need biomathematics for that. We need to be able to identify and characterize those behaviors, those values that matter to us as a community, and espouse them and teach them to our children and learn them ourselves.
Dr. Shervington, do you think Dr. Martin's idea works for all racial groups?
Absolutely. And as you're talking, Dr. Martins, I'm thinking of Ubuntu. I am because we are. And our mind is interpersonal. We know who we are through the eyes of someone else. We cannot survive as a species without each other. So Dr. Martins, talking really about love, generosity, and compassion, I think we need to get back to that. That's very, we certainly, if you're depressed, if you're stressed out, we have drugs, but we have found, especially with things like post-traumatic stress disorder, the most preventive factor is the quality of the social support that you have in your life. And I think we need to get back to that. We belong to each other. We're here to support each other. And so I like, I would love to think about what can we measure in compassion? Do we see an increase in oxytocin in our body? Dr. Martins, maybe that's something, we need to think about research. What are those measures and how do we really encourage ourselves and each other to know that this is the best way we can survive? I just wanted to add one thing. One of the Dr. Carlisle mentioned COVID and mental health concerns. Our children are having a really hard time. And I know, Miss Drew Ivie, you sent everyone, I think, in your circle, the recent CDC report that shows that our youth are really suffering with symptoms of depression and anxiety, and Black children are killing themselves at rates we have not seen before. So now than ever, I think Dr. Martins, this idea of compassion, caring, and generosity, we're being called to turn up a little bit more and support the young people who we are going to depend on them to move this world forward.
Dr. Carlisle, those ideas sound so obvious in a sense of need in our communities. But you've worked with 3 different governors in state government. Is the culture in that environment likely to listen to these observations and hear them and say, we need legislation to enact that? Or are they not going to be willing to that because they have a rubric under which, if we would only behave better and stop killing each other and stop taking drugs, we wouldn't have any of these problems?
Well, that's a really, really interesting question. And I would say the answer is maybe surprising. Now, of course, when I was up in Sacramento, I was working with people who are primarily focused on things like health and human services. But in that environment, I would say there was, regardless of the administration, Gray Davis, Arnold Schwarzenegger, Jerry Brown, regardless of the administration, the bureaucrats that I worked with had demonstrated, I think, a surprising, probably to some people, degree of compassion, which Dr. Martins talked about, receptivity and awareness of these challenges, especially at the community levels. Now, of course, in government, there's always the question of what you can do versus what you want to do. And the challenge of government is often converting what you want to do into what you can do. But I'd say I encountered really very little ideological resistance to improving the health of California's diverse communities. And then when you think of Governor Gavin Newsom, he's really recognized, I think, as sort of the healthcare governor. That's one of his major priority areas. And I know that this is a significant area of focus of his as well. So at least in the state, I can't speak for federal government, but for the state of California, there's very impressive alignment with some of the priorities that we're talking about here today.
Dr. Martins, and in each of you, what do you see as the biggest challenges in communicating what we're discussing and the importance of mental and behavioral health in the communities? What is that something we can do? Is that something we are doing? Is that something we need to do more of? Let me start with you, Dr. Martins, and then Dr. Shervington and Dr. Carlisle.
You know, the greatest barrier, as I see it, is the fact that there is no expectation of what I expect from you as a neighbor or what you expect from me as a neighbor, right? We assume that somehow these things are intuitive, but unfortunately they are not. What is lacking are role models and champions. We really need to not only talk about being compassionate and caring one to another. Children need to see it. Young adults need to see it. Elders need to demonstrate it so that the younger ones can understand what does it really mean, right? What does it really mean to be compassionate? You know, for instance, I see many times in the community how we respond sometimes to violence when it's coming from some specific quarters, right? Like, look at the good example of Tyrell Nichols, right? When the way he was brutally beaten by those cops. Well, the truth of the matter is that the nation went up in arms over that. And I looked at that scene, I analyzed it. I'm like, wait a minute, this is what rival gang members do to themselves every day, right? We as a community raised men to do this to another man. Now they're in police uniform. Makes it look like it's a police problem. But how did we end up raising men that could do this to another man, regardless what they're wearing? It is because we are becoming distant from ourselves. We are not honoring ourselves. We are not thinking that we need ourselves. We're beginning to think more of ourselves as stools upon which we can step to get onto a higher elevation, when the truth really is that I can truly stand when you hold me up, and you can truly stand when I hold you up. For as long as you think you can stand on my head, I will always look for ways to bring you down, because if we don't rise together, we will not rise. So I really believe that it is time for us to go back to the drawing board and begin to define for ourselves, what are the values we want to embrace? How do we want to express our humanity? Like in the Himalayas, they salute themselves, namaste. You know, the God in me recognizes the God in you. Do we treat ourselves like that? People you don't even know, they just hate you for whatever reason, right? And we're all human, we're all here, you know? And it's incredible to me how, as a nation, we rush to other parts of the world to help them, right? American blood is shed all over the world, helping and serving humanity. But we don't even need to shed blood in our backyards. All we just need to do is be a little bit nice, show more compassion to ourselves, but we are externally focused. And it's important to be balanced. Charity has to begin at home. Compassion has to begin at home. People have to feel loved and supported as Americans, so they can take that love and compassion out with them to the rest of the world. So the short answer to your question, Sylvia, is that we need more role models. Our children, the young adults, need to see the elders demonstrate these values that will help us, you know, live the longest we can live and the happiest we can live.
Dr. Shervington, aren't we all a little long in the tooth to be learning this and demonstrating this? Isn't this something that the young people need to take on and demonstrate in their circles, you know, gang member to gang member, or opposing gang to opposing gang? What age group are we talking about providing leadership? This is so profoundly positive, but who can be heard?
I want to deepen a little bit, go down a little bit more with the amazing words. I feel like I'm in church with Dr. Martin, so thank you. That, you know, I think we learn to be humans at home. It starts in those, some would say prenatally, and it certainly happens in the bond between an infant and mother and father, whomever those caregivers are. But we do know that these factors that impact adults can interfere with that space. That's a really divine, sacred space, that the more we can carve that out and attach and attune with our children, the more they'll feel loved, cared for, experience their humanity, and not need to harm others. I worked with some men in New Orleans who had been involved in various degrees of violence, and they were in gangs. And something they told me that has stayed with me, we went to do a focus group, and I ended up doing therapy with them for 6 weeks because they wanted to talk. And one of the things every one of those men said was, as children, no one saw them. And they said, we weren't seen in our home. And specifically, every one of those 15 men repeatedly said, we jumped the porch at 13. And we found that we tried to create family and brotherhood because they weren't being seen and cared for in their homes. And we know all the structural factors that can impact our communities. I don't think people in our community get up and say, oh, I want to be a bad parent today. I want to go do drugs today. We know that some of those forces, or I'm unemployed, I'm unhoused, are structural and social factors. So I think there are multiple levels at which we can address some of these issues. Certainly, as psychiatrists and mental health providers, we need to get out into our communities and share what we know about mental health and mental well-being. We need to destigmatize, as Dr. Carlisle said, seeking help if we get to places of overwhelm. And we need to support the work that's going to try to create a more just, and now I'll have to say verdant world. We see the climate that's happening in Los Angeles. We're going to have to attend to climate challenges in our communities. But certainly we need to work at multiple levels so that parents, caregivers, and their children in those crucial years, 3 birth to at least 3, when we can build solid little potential human beings, that the caregivers have the resources they need to be able to help to attune and mold their children into the best version of humanity that they can be.
But mother is not home to do that. Everyone has to work wherever they can work. And so who should be leading that in the home where the mother is working not 1 but 2 jobs to make ends meet for the family? It seems like it's a very difficult challenge. Dr. Carlisle, you suggest that behavioral health is evolving in medicine, but is the kind of behavioral health that's evolving tailored to the needs that these 2 doctors have described? Or is it just giving it a name and giving it some support financially at the government level, but not really making it work on the ground? It seems to me it's very difficult to make it work on the ground in the way that they're describing it. What's your reaction, Dr. Carlisle?
Yes, I think in all honesty, we have a ways to go as an American society before we can kind of reach a state, and I'll use the terms that both Dr. Shervington and Dr. Martins used. I'll call it verdant compassion. And I think there are societies in the world that are closer to that state than we are.
I like the phrase.
What can we learn from some of these societies? Because nobody should ever have to fall through a safety net in this country, the richest and most powerful country in the world. We have the ability to eliminate these problems. And we need to strive to their elimination so that nobody is left behind. That child of the mother who's not at home because she's working 2 full-time jobs, yes, she has to work those 2 full-time jobs, but we should have a solution in mind for that child, for those children, that can embrace them while at the same time allowing their mother to do what she has to do to support them economically. That is a just society. That's a compassionate society, and that's a verdant society. The challenge that we have is that too many people are pushed to the wayside. And just a couple of examples, one that I say all the time is, here in South Los Angeles, you think twice, maybe 3 times before you call 911 for somebody that's having a mental health crisis. That's a reality. That's unfortunate. That's a tragedy. And if the worst situation occurs where somebody gets killed as a result of that crisis, adjudicating that crisis, that's the ultimate tragedy. We also have a situation where it's really hard to find behavioral health practitioners in so many of our communities. That's unfortunate because it means that lives are being wasted, energy is being wasted, emotions have nowhere to turn to, and bad things happen like that. This does not have to be the case. I would challenge everyone to keep working to try to get us to that state of verdant compassion that our other panelists have spoken about, because yes, we have the ability to do it. The question is, do we have the will? And I think that our national will is changing more and more, perhaps led by states like California. I think that we can get there. But we have to keep pushing on this to make it happen.
Excellent. A final question for all 3 of you is, what role does cultural competency play in providing mental and behavioral health services? Dr. Shervington, will you start?
Of course, when we're providing services, we need to center those whom we're serving. And part of centering the person is understanding the forces who make them who they are. And so it's really, and my attitude as a psychiatrist is I'm not going to have the experiences of everyone I work with. There's certain cultures that are closer to mine and I understand, but I can allow those whom I serve to teach me, to share with me who they are and how I can best serve them. And so I think one has to be very humble in the space. One has to, and I'm speaking again as a physician, a psychiatrist, one has to enter with a primary focus on, I'm centering those who I'm serving and I'm bringing whatever competence and skills I have to meet who they are as best as I understand how they're presenting. And so cultural competence, it shouldn't only be referenced only to communities of color. It's everyone has culture, and there are multiple types of culture. And I think we need to keep challenging ourselves to best understand whom we're serving and to wrap our treatment within how they are experiencing their lives as they come to us and the problems they're asking us to help them to resolve and the healing that they're looking for.
Dr. Martins, thank you. Dr. Shervington, thank you. What is your take on that? What is the racial, ethnic component of this challenge?
A few years ago, that term, cultural competence, came to being, and then it was modified, cultural humility, and then we keep watering it down because we are learning increasingly that we really cannot be competent in a culture that we are not raised in. And one of the elements in the ghost model of compassion was objectivity. Because if you look at compassion, compassion is your ability to respond to pain and suffering of another person. You're not responding to the person, you're responding to their pain and suffering. So regardless who they are, where they've come from, what their culture is, your duty as a care provider is to respond to that pain and relieve or alleviate that suffering, regardless who that person is. If we can just be that objective in clinical interactions and engagement, we will move the needle a little bit forward. And then maybe the community will learn that from us as healthcare providers, when they feel they can come to us without being judged, when they feel they can come to us and we create very safe spaces for them to be fully disclosing with us about what is going on in their lives. That is not what we have right now. And that is what we need to have. Because as a matter of fact, if you don't care about people, you have no business taking care of their health.
All right. Dr. Carlisle, this is a question from the audience. I'm going to turn now to some of the questions that have come in. Are mental health problems created due to psychological problems, such as when parents argue or fight? Is it spreading by mouth-to-mouth communication, especially in growing teenagers?
Well, we don't really know or understand well the etiologies of many of the behavioral health issues that people face. But I would say, again, they are ubiquitous. Virtually everyone at some point in their life has been there. And maybe they've had an intervention that's helped them out, maybe not. But this is a commonality that we all face. And then some of these circumstances can be much more extreme, but we don't know exactly what causes them. But if you look at our society, out here in Los Angeles, where we are right now, there certainly is this overlap between mental health issues, behavioral health issues, homelessness, drug abuse, unemployment, and health outcomes. These things all lead to adverse social determinants of health. If you're homeless, your life expectancy can be reduced by 15 years on average. That is catastrophic. Many people who are in any of these circumstances, you see them at any one time, they didn't start out that way. Something happened to them. And here they find themselves a year later, 2 years, 3 years later, and they've got labels. Oh, you're crazy. But they weren't crazy 2 years ago. And this is why I think we need to look at some of these other causal factors. And I'm not talking about biological causal factors. I'm talking about social causal factors, because it's those social causal factors that we can eliminate very, very rapidly with appropriate social policies. We can do a lot in this area. And I think, we have the capability to do this. We can prevent a lot of the suffering, especially the behavioral health suffering, with appropriate public policy. And again, I would urge everyone to just not forget to think about that. And one thing, again, speaking to what Dr. Martins just mentioned as well, one thing we all have in common, no matter what our circumstances are, we're all human beings. And it doesn't matter what that person is in front of you, if you can identify with them as a human being. They can be a wealthy CEO or a homeless person who abuses IV drugs, but they're still a human being. And when you approach them as a human being and treat them with respect, you automatically reduce a lot of barriers between the provider and the patient. And that is an important first step.
Thank you. But let me ask a question that shows some compassion to our providers, all three of you here. How can you provide the kind of care you're all describing, which sounds so warm and specific to the lives of the people that you're helping? How can you help with those problems, which are so complicated and difficult, without burning out yourselves? Dr. Shervington, do you want to try to answer that?
Yeah, I have a favorite Buddhist priestess who talks about empathic distress, and the idea being that if you don't pay attention to the source, how you're refueling your own capacity for empathy and compassion, you will fall off and be distressed and have burnout and disconnection. I think it's really important, and I think as I've gotten older, what are the things that are meaningful in my life? What are the things that refuel me? Walk up in the hills, or going to the beach, or being with my family. I think we each have to carve out that space, or I do that. I carve out that which is creative. That I love seeing people dance and sing, and I find joy. We're wired. Part of our 7 emotional needs is to have joy. So how do we have joy at the same time attend to that which we are passionate about? And for me, that is I see myself as a healer. I sometimes, I've been trained as a doctor, but I am joyful when I feel I've helped someone along their healing journey. And that helps me to balance when I have to put my needs to the side a little bit to serve someone. And then knowing that I've put my needs aside, at some point, I'm going to have to restock and refuel. But there's a lot of joy I find in service.
Well, that means that you will keep doing more than any one person should be trying to do, as I hear you saying that. But there is joy in service, but there has to be something else. Dr. Martins, do you understand what I'm saying? She's dedicated, you are dedicated, Dr. Carlisle is dedicated to service, and yet the body that you all were talking about earlier it's a finite instrument. It's a finite instrument. The heart and the mind, the spirit, they're finite instruments of our activity. So how do you prevent burnout, Dr. Martins?
You know, it's interesting that Dr. Shervington talked about empathic distress, and I hear about compassion fatigue. I agree with empathic distress. I don't agree that compassion fatigue is a real entity, because compassion cannot hurt you. If anything, anytime you are nice and compassionate to somebody, you gain more. Even when it might just be words that you spoke, but at the end of the day, the biological benefit that accrue from that act is more towards you than towards that other person. The reason people experience compassion fatigue is because they don't truly practice compassion. You cannot judge the person you're trying to alleviate their suffering. It all depends on the mindset we bring to our work. Okay? There are days I walk into the clinic and I have 24 people on my schedule. And as soon as I go in, some of them will tell me, oh, I don't need anything, just refill my medication and I'm out of here. Because they know that there are areas that might need that time. They've known that practice well enough at THE to know that there might be somebody else like that. But I have colleagues that once they come into the office and they see 24 patients on their schedule, they become unhappy. Why are you double booking me? Why are you doing this? Why are you doing that? And then they now see, if they are lucky on that same day, their first patient happens to be a difficult patient, they just ruin that day for themselves. Instead of waiting to worry, we are very preemptive, and as presumptive, we create a lot more problems than there are in the healthcare setting. You know, the truth is that not every human being is eligible to be in a care setting. And I'm looking forward to the day that healthcare providers will wake up every morning and examine their own worthiness to put themselves in another person's life with the goal of alleviating that suffering. Because we don't wake up equally worthy of that privilege every single day, but we are plunged into it anyway. And as a result of that, many of us walk away many more days unhappy with what we've done because we don't truly realize why we're there and why we're doing it. Healthcare cannot be for money. It's got to be because you care. Yeah, you'll be paid doing it, but your drive should be that you want to really help. You want to care. You want to be compassionate. So I really think ultimately, at the end of the day, all of us in the caring profession, we need to learn to self-assess and evaluate ourselves every single day and present ourselves, our best selves, actually, to the patients so we can also benefit the most from that encounter.
Well said, Dr. Martins. You always touch us with the spiritual aspect of your perspective. A community faculty member writes in and says, thank you all for remembering the compassion for the person. Thank you, all three, for remembering the compassion for the person. There's many, many other questions. This is a topic that has really galvanized the interest of your viewers. And I know we've just touched on it, but let me touch on something that's a little more everyday challenge. There's a long list of unhealthy behaviors that are not recognized as mental health issues: smoking, diet, drinking. Would you comment on this aspect of our behaviors? Is this a mental health problem, or is this a health problem of another nature? Dr. Carlisle, would you try to answer that?
Sure. I know that we're running out of time. I'll try to be succinct, and I just want to say, wow, and thinking about the comments of my co-panelists that they just made. You know, these at one point in the continuum, these can be not aberrant behaviors whatsoever, although I would not put cigarette smoking in that category whatsoever. I think it is aberrant under any circumstance. But at extremes, or as you move more and more into them, they can become manifestations of what I would call behavioral health issues. They could be indicators of anxiety and stress and depression. And these are all things that we look for as physicians when we're talking to patients. We look for these little clues, the tells that there may be something happening in their lives that they're not happy with or not entirely in control of. And when we see somebody maybe taking up cigarette smoking, drinking more alcohol, it's not just that we think about. It may be what is the additional stressor that person is facing. And that's what we do. We try to connect those dots. That's part of being a physician. That's part of being an effective healthcare provider. And it's part of practicing healthcare and medicine compassionately. Again, looking at the holistic person.
And putting all parts of it together is what I hear you saying. Well,
Indeed.
we've come to the end of our hour. We could obviously go on for another hour or two today. Thank you, each of you, Doctors Martin, Shervington, and Carlisle, for participating in this community forum. This discussion really indicates that we have to have more on this particular topic. I thank everyone who attended in the audience. We had a big audience today, 45 people. That's a large audience for our community meetings, and thank you for attending. It means that you have the same questions and more that we've been discussing today. We're grateful that you tuned in to hear. Please share and interact with our forum on social media by using the hashtag CDU Community Forum, and bookmark the Community Forum page on our website to get a heads up on our next event. I look forward to seeing you all then, and have a wonderful rest of your day. Thank you, panelists. You're all just wonderful. I really enjoyed hearing from you all today. Bye, everybody.